Yeah, visible,
Yes,
but the letters are very, very small.
Good evening, sir.
Good evening. Go ahead.
Question is hyponatremia and hypokalemia, sir.
I think hyponatremia we discussed in the last class itself. Uh, anyway, okay. Having prepared, you go ahead. I thought
Yes.
more hyperkalemia will be more useful. Hyponatremia, I think we talked in the last class, isn't it?
Yes.
How to calculate. Okay, right, go ahead.
Yes. Hyponatremia is a common electrolyte disorder which is defined as a serum sodium of less than 135 milliequivalent per liter, sir. Types of hyponatremia: mild, moderate, and severe, and classification and evaluation of hyponatremia and its treatment. Hyponatremia is divided into asymptomatic and mild one, and another one is symptomatic. Asymptomatic is asymptomatic and mild symptoms such as headache, lethargy, confusion, and in symptomatic one it is ataxia, confusion, obdentation, seizure, coma, and respiratory depression, which is considered as symptomatic severe hyponatremia. In mild hyponatremia, determine serum osmolality. Normal serum osmolality is 280 to 290 milliosmol per kg. If it is less than 280, which is hypotonic hyponatremia. If it is 280 to 290 milliosmol per kg, which is isotonic hyponatremia. If it is isotonic hyponatremia, then check for hyperproteinemia, hyperlipidemia, and laboratory artifacts. For hyperproteinemia, the treatment is chemotherapy, and for hyperlipidemia, the treatment is statin therapy, and for laboratory artifacts, repeat the serum sample. If serum osmolality is greater than 290 milliosmol per kg, it is called hypertonic hyponatremia. In that, check for hyperglycemia, check for recent use of mannitol, sorbitol, and recent use of radio contrast media. If so, if it is hyperglycemia, then the treatment is insulin and IV fluids. If there is recent use of mannitol, sorbitol, and radio contrast media, then for treatment it should be avoided. In hypotonic hyponatremia, assess the volume status such as vitals, orthostatics, jugular venous pressure, mucous membrane, skin turgor, peripheral edema, and blood urea nitrogen. If it is hypovolemic hyponatremia, assess the urine sodium. If it is less than 20 milliequivalent per liter, then it will be extrarenal cause such as GIT, and the causes are vomiting, diarrhea, bowel obstruction, and third space loss. And the treatment is IV fluids. If it is bowel obstruction, then treatment is relieve obstruction. If the urine sodium is greater than 20 milliequivalent per liter, then it will be renal cause such as thiazide diuretics, mineralocorticoid insufficiency, cerebral salt wasting syndrome, and salt losing enteropathies. In thiazide diuretics, if it is the cause, it should be avoided. And for mineralocorticoid insufficiency, steroid supplementation is the treatment. And for cerebral salt wasting syndrome, hydrocortisone and hypertonic saline is the treatment. For salt losing enteropathies, treat the underlying causes. If it is euvolemic hyponatremia, usually the urine sodium will be greater than 20 milliequivalent per liter. Then check for urine osmolality. If it is less than 100 milliosmol per kg, then polydipsia and low solute intake will be the cause. If urine osmolality is greater than 100 milliosmol per kg, then the causes are syndrome of inappropriate antidiuretic hormone, hypothyroidism, glucocorticoid insufficiency, and drugs such as cyclophosphamide and chloropropamide. For syndrome inappropriate of antidiuretic hormone, the treatment is fluid restriction and Vaptans. For hypothyroidism, thyroxine replacement therapy. For glucocorticoid insufficiency, steroid replacement therapy, and drugs which causes hyponatremia should be avoided. For hypervolemic hyponatremia, check the urine sodium. If it is less than 20 milliequivalent per liter, and the causes are heart failure, nephrotic syndrome, and cirrhosis. If it is more than 20 milliequivalent per liter, and the cause is renal failure. For heart failure, the treatment is salt and fluid restriction, angiotensin converting enzyme inhibitors, diuretics, and beta blockers can be used. For nephrotic syndrome, treat the underlying cause, and for cirrhosis, salt and fluid restriction, Lasix and spironolactone. For renal failure, the management will be salt and fluid restriction, dialysis, and transplant will be in severe renal failure patients. Clinical features: mild and moderate hyponatremia are frequently asymptomatic. In case of severe hyponatremia, the primarily results in neurological manifestations, especially cerebral edema. Malaise and nausea are the earliest symptoms. Manifestations of acute hyponatremia. In neurological, it causes apathy, agitation, confusion, lethargy, coma, abduction, headache, muscle twitching, seizure, coma, respiratory depression, hyponatremic encephalopathy. In CVS, the manifestations are seen only when the serum and sodium is less than 100 milliequivalent per liter, and it will cause hypertension and bradycardia, increased blood flow to the liver and heart, and decreased blood flow to the muscle. In musculoskeletal system, muscle cramps will occur and weakness due to strenuous exercises, and in gastrointestinal tract, it will cause anorexia, vomiting, and diarrhea. In chronic manifestations, focal weakness, ataxia, hemiparesis, and positive Babinski sign. Correction of sodium. For acute cases, it should be corrected in 0.6 to 1.2 milliequivalent per liter per hour. For chronic cases, 12 milliequivalent per 24 hour for low risk patients and 6 milliequivalent per 24 hour for high risk patients. And hypertonic saline should be infused at 1 to 2 ml per kg per hour. Infusion rate can be reduced or stopped once symptoms improved. Formula for sodium correction. Sodium deficit is equal to total body water into desired sodium minus present sodium. First half of deficit should be corrected over 8 hours, and second half of deficit should be corrected over 1 to 3 days if symptoms persist. Serial serum sodium monitoring to be done every second hourly. Usually CNS signs and symptoms improves within 24 hours. For complete recovery, it will take up to 4 days. Complications: if hyponatremia is corrected delayedly, it will cause neurological injury. If it is corrected very rapidly, it will cause cerebral hemorrhage, congestive cardiac failure, and central pontine osmotic demyelination. If hypertonic saline used for hyponatremia correction, then it will cause complications such as hypokalemia, hyperchloremic metabolic acidosis, transient hypotension, pulmonary edema, and coagulation defects. Anesthetic considerations in hyponatremia. For all elective procedures, serum sodium levels have to be corrected to 130 milliequivalent per liter. Failure to do so, which results in intraoperative cerebral edema. This may result in delayed post-op recovery, reduced minimum alveolar concentration of volatile anesthetics, and agitation and confusions. So this is for hyponatremia questions.
Yeah, okay. So always sodium is associated with water. So whenever you talk of sodium hyper or hyponatremia, you must see the fluid status or volume status in the patient. For that, the
Yes.
best assessment is only your plasma osmolality. So based on that, whether you have to can have euvolemic, hypovolemic, or hypervolemic, both for hypo and hypernatremia. That is the basic, the fundamental concept that we should clearly understand. And again, hyponatremia can be mild, moderate, or severe. So less than 120 is considered severe. So 140 to 130 is 130 to 125 is considered mild, and then 125 to 120 moderate, less than 120 very severe. So especially in the elderly people, it will cause a lot of cognitive dysfunction the post-operative period, and it may occur suddenly for no fault of us at all. So we have to be very watchful and correct. Normally, milder forms will get corrected with 0.9% saline itself. Only very severe forms will require hypertonic solution like 3% or even 5% may be required. For shorter correction, like sometimes in PURP syndrome, where there is a dilutional hyponatremia, apart from using diuretics to remove the excess water, sometimes they advocate sodium bicarbonate as a bolus of 75 to 100 ml to correct the hyponatremia, which may be in the milder version, which may sometimes produce some symptoms of vague CNS disorientation, all these things. So that is also a accepted form of treatment apart from your regular 3% and 5% saline. Okay, right. Go ahead with the second half.
Yes, hyperkalemia. It is defined as serum potassium of greater than 5.5 milliequivalent per liter, and in very rarely hyperkalemia occurs in normal individuals because of the kidney's ability to excrete large volume of potassium. Etiology, and the causes are pseudo hyperkalemia, transcellular potassium shift, potassium overload, decreased potassium excretion, and drugs. In pseudo hyperkalemia, It is in vitro sample lysis, marked leukocytosis, marked thrombocytosis, tourniquet use, and abnormal red cell morphology such as somatocytosis. And in transcellular potassium shift, acidosis, hypertonicity, heavy exercises, and drugs such as succinylcholine, beta blockers, insulin deficiency, and hyperkalemic periodic paralysis. Potassium overload causes are IV potassium supplementation and food and drugs containing potassium, gastrointestinal bleeding, crest injury, cell destruction after chemotherapy, rhabdomyolysis, and transfusion of aged blood. And in decreased potassium excretion causes a renal failure, aldosterone deficiency, type 4 renal tubular acidosis, sickle cell disease, systemic lupus erythematosus. And drugs causing hyperkalemia are angiotensin converting enzyme inhibitor, non-steroidal anti-inflammatory drugs, trimethoprim, pentamidine, mannitol, cyclosporin, heparin, and potassium-sparing diuretics. Pathophysiology of hyperkalemia. Manifestations of hyperkalemia due to impaired neuromuscular transmission and skeletal muscle weakness manifested due to persistent depolarization and its inactivate sodium channels in muscle membranes. Hyperkalemia causes reduction in upstroke velocity and reduction in resting membrane potential of cardiac cells and reduction in duration of cardiac action potentials. Hyperkalemic cardiotoxicity is enhanced by hyponatremia and hypocalcemia. And sine wave pattern in ECG due to reduced rate of ventricular depolarization by hyperkalemia. Clinical features. Skeletal and cardiac manifestations seen if potassium is greater than 6 milliequivalent per liter. Neuromuscular manifestations are seen if potassium is greater than 8 milliequivalent per liter, and the manifestations such as ARF manifestations are
Yeah, go ahead.
cardiovascular manifestations such as ventricular fibrillation and diastolic arrest. Gastrointestinal tract manifestations are anorexia, nausea, and vomiting. Treatment. Stop the drug which contributing to hyperkalemia. Stop further administration of potassium. Monitor serum potassium and ECG. And in case of aldosterone deficiency, the drug 9-fluorocortisone can be used. For physiological antagonism of hyperkalemia, calcium is used, which is available as formulations such as calcium chloride and calcium gluconate. And its mechanism of action is which stabilizes myocardium and reverses membrane excitability. And shift of plus back into the cell by insulin with glucose infusion, which can be given as 5 to 10 international units of regular insulin, IV bolus with 50 ml of 50% dextrose, and sodium bicarbonate can be used, which acts by increasing extracellular pH, and beta agonist can be used, which increases sodium potassium ATPase pump activity, and by hyperventilation. Eliminate potassium from body by using sodium polystyrene sulfonate, which exchanges sodium for potassium in GI tract, and diuretics and dialysis can be used. Anesthetic considerations of hyperkalemia. Elective surgical patients should have normal potassium levels, and stress during surgery itself will decrease potassium to 0.2 to 0.8 milliequivalent per liter. Avoid succinylcholine, ringer lactate, and respiratory and metabolic acidosis. Mild hyperventilation is desirable. Careful perioperative ECG monitoring is mandatory. And neuromuscular function is monitored as hyperkalemia potentiates neuromuscular blocking action. ECG and hyperkalemia. Hyperkalemia usually associated with wide variety of ECG changes. ECG changes may be the first indicator of hyperkalemia. Then the first change is symmetrically peaked tall T waves and the shortened QT interval. Hyperkalemic Brugada sign seen in critically ill patients with serum potassium greater than 7 milliequivalent per liter, and it causes pseudo right bundle branch block and persistent ST elevation in at least 2 precordial leads. And ECG changes of hyperkalemia. ECG stages of hyperkalemia. In mild stage, there will be increased PR interval and tall and peaked T waves. In moderate stage, it will be prolonged QRS complex, loss of P wave, and ST segment elevation, ectopic beats, and escape rhythms. And in severe stage, it will be progressive widening of QRS complex and cardiac arrhythmia such as ventricular tachycardia, ventricular fibrillation, bradycardia, and cardiac asystole. And conduction abnormalities such as right bundle branch block, left bundle branch block, and advanced atrioventricular blocks and fascicular blocks. That's all.
Okay. So what about dialysis? There is a role for dialysis. Ultimately, hemodialysis is the method of removing excess potassium, okay, especially with patients with CKD. So the order or calcium gluconate, the first drug in acute emergency, there is a sudden rise of potassium to protect the myocardium and prevent arrhythmias, stabilize the myocardial cell membrane. Then comes the inhalation, nebulization with beta 2 agonist and
Yes, sir.
your diuretics, potassium sparing diuretics if there is a fluid overload also. Then comes the treatment with your slower chronic hyperkalemic patients who have always 5.5 to 6 milliequivalents. They can be put on the resins, binding resins like caselate and other things orally as well as rectally. And is there any surgical indication for treating hyperkalemia? Can you do any surgery for some type of hyperkalemia?
No ideas.
No idea.
Russian speak.
Russian rhabdomyolysis, very good. Any other condition?
Contracture release bonds.
Contracture release, you don't treat hyperkalemia. The hyperkalemia will be produced if you use suxamethornia. But some kind of surgical conditions which cause hyperkalemia will be corrected only when you do the surgery. And which are all the surgeries during which intraoperative hyperkalemia is possible? You can get intraoperative hyperkalemia during liver transplantation or liver surgeries, number one. Number two, you can get hyperkalemia in parathyroid surgeries. You can get hyperkalemia during renal transplantation. No? So these three surgeries can produce intraoperative hyperkalemia. Necrotic bowel, the intestines, that can, unless you exercise that can produce hyperkalemia. So once you resect that necrotic bowel, hyperkalemia will automatically get corrected. Similarly, compartment syndromes, where the limb is under severe edema. Unless you release that edema, patient can die of hyperkalemia. Okay? So these are all surgical indications for correcting the hyperkalemia, which will not get corrected by your regular treatments. That's all. But ultimate treatment for any type of hyperkalemia is hemodialysis. You can remove that by dialyzing the patient, so that you can add to this answer. Okay. What is the next topic?